wall. Or a chair right here. Just like in the pictures, there's a chair in your notes. They have to hold on to something. And this is because if they don't hold on to something and they lift their leg, not that they'll stumble or lose their balance or anything. But they're going to have to contract muscles that will probably lock the SI joints down and then change this. But we need them to be stabilized. So most, in this setting, it's probably going to be a wall. But it needs to be like this. Hand against the wall, like that. Not like this. I see that all the time. And no one ever taught it like that. There's some problems. Not only that it's creepy, but they're not fully vertical. And also, they might change their gait so they're not hitting the wall. Especially if they're closer, they might kind of like scrunch their hips to do something so they don't knee the wall. So we're never going to have the patient in that position, ever. That's wrong. That makes sense? Everybody get that? Yeah. So the memo. That's wrong. This is right. Or, if I had a chair right here, I could hold on to the chair. I don't have to be against the wall, but in this setting, the wall is probably the easiest thing to hold on. Okay, so that's rule number 1. Rule number 2, we have landmarks. With the patient facing this way, I can test both left and right SI joints. So once the patient is positioned properly and they're holding onto the wall or a chair or something, I don't have to have them move. So the landmarks are going to be PSIS and the midline of the sacrum. The sacral contact needs to be inferior to the PSIS contact. So thumbs are generally like this, an inch, inch and a half lower. You don't necessarily have to write that down, but I had a few incidences where I look over and the person had their thumb, yeah, in places that they didn't need to have their thumb. Like I couldn't see the tip of their thumb. We'll just say that. And I was amazed that their partner was totally okay with it. It was like doing a DRE through the clothing. So I now have to, I got to think of every angle possibly that you can screw this up. So that's one of them. So it has to be inferior. The sacral midline contact has to be inferior to the PSIS, but not too inferior. Let's just say it needs to be superior to the sacrococcygeal joint to be as professional as possible. Okay? And in general, you're not even going to be in the crack at all. The gluteal folds will be, like the deep valley of the gluteal folds will be inferior to your contact. So generally, this part of the sacrum is right where the low back flattens out and then the glutes come in like that. So it's still above that area. So it's really not a very invasive area. That's kind of the take home. But it does need to be lower. If it's right at the same level, you're not going to be able to notice anything. If it's above that PSIS contact, it's going to make your head explode. So like that. If I'm testing the left SI joint, my thumbs are like this. See that? If I'm testing the right, I switch. Thumbs are like that. Okay. The last rule I forgot to mention in the other sections before it was too late. One of your thumbs needs to be on skin. Guess which one that is? The PSIS thumb. And it's pretty easy. Most of the time, you just have to be just underneath the waistband. It's really easy to do. It can't be on a shirt if the shirt's long, because when you're moving, you might notice a shirt restriction. The shirt starts to tense up, and that actually messes things up. You can't have on the pants here and on the pants here, because as they're moving their legs, the pants will tense up, and you'll lose your contact. So it's got to be on skin for the PSIS. So those are the rules. You have to abide by those, or you're going to mess these up. Now, eventually, when you're good at this, I don't always abide by that, especially that one. Sometimes I'm on the waistband, not a big deal. I can usually track the PSIS underneath the waistband and underneath the skin. It's just I've done this so many times where I know where the SI joints, or I know where the PSIS is going. That's kind of what I'm doing, is I'm tracking the PSIS. So those are general rules right now in class. If I were to flex this SI joint, what would this PSIS do?
Go inferior.
Posterior, inferior, yeah. It would go posterior and inferior. So if I was comparing these two spots, what would happen?
Go closer together.
They would approximate. And they might approximate like, I'll just put this up here so everybody can see. They might approximate like this, or like this. It might do something weird. But either way, they're going to be moving towards each other somehow. And that's SI joint flexion. So how do I create SI joint flexion?
Lift.
Have them raise their knee up to about 90 degrees. And that tenses up the hip, and then tenses up the SI joint, and then flexes that SI joint. So with SI joint flexion, meaning the same side leg flexes up to 90 degrees, we notice what? Approximation. Somehow, like this, like that, like this maybe, kind of coming down like that, closer together. They can be weird angles, because the SI joint's a weird joint. How do I do extension now?
Lift the leg behind.
Have them bend over. The other leg.
Are you guessing, or why does that work?
Go like that.
You wouldn't have them go to leg back because I'm sitting here.
Take a step forward down.
No.
Lean their torso back. Like that.
Up and down backwards.
Yeah, no, those are, I mean, you're thinking right. Actually, we do have the opposite leg flex past 90 degrees. So, to cause extension at this SI joint, I'm going to flex the opposite leg past 90 degrees. So, testing the left side, if I take my right hip and I flex it to 90 degrees, it doesn't do anything to the left side. But if I flex it past, watch this hip. I have to extend that hip to get it up there. So, I'm extending my SI joint by doing that. In addition, there's a, when you do this motion, all the way up here, it flexes the low back, and when you flex L5, the sacrum counternutates. And counternutation is extension of the SI joint. You don't necessarily have to remember that, just remember that when the opposite leg goes past 90 degrees, you have to extend this leg. So in your notes, I believe it says, flex the leg in a similar way. And I have no idea why that's written that way, because it's not true. The opposite leg, if I'm testing the left side, the right hip needs to flex above 90 degrees. There'd be no reason to do the opposite side if it's not flexing above 90 degrees, because it doesn't affect this SI joint. So this is how I do this. I'm going to test this SI joint. I tap on the patient. I never tell patients lefts and rights. I say, go ahead and lift this leg up to 90 degrees. I lift it up. What should happen? Approximation. Keep my contacts there, because I'm still testing the left SI joint. I tap on this side. Lift this leg up past 90 degrees, as far up as you can. If you can get your thigh against your stomach, that's good. And then what happens?
Approximation.
What happens to my contacts? They move away from each other.
Away.
But how?
But-
Deflection. Make up words.
The PSIS moves up on the left. Superior.
So the PSIS will move. The sacrum's going to move away.
Yeah, that's right.
Because we're standing on that leg. The PSIS isn't going to move at all. It's actually the sacrum's going to move away, but that's still SI joint extension. If you think about it, it would actually be this side. This is extension. So the PSIS and sacrum are moving like that, but so is this. And that's actually what we're doing. We're actually getting this motion to happen. So what you'll probably notice is this.
Goes down.
That moves away, or away this way. It could be a weird angle. If they both move, as long as they're moving away, that's fine too. But most of the time you're going to see that sacrum move away. So, what is that going to tell me? What if I have them flex this leg to 90 degrees? That moves, that approximates. Flex this leg past 90 degrees, nothing happens. Extension or restriction, essentially, of that SI joint. If I have them flex this leg to 90 degrees and those don't come together, flexion or restriction. To do the other side, I just switch my contacts, do the exact same thing. Flex the same side to 90 degrees, opposite side past 90 degrees. Flexion, extension. Does that make sense? It's pretty easy. Probably the hardest part is following the PSIS as it moves. That should be pretty easy as long as you're focusing. You don't have to push too hard. You actually need to push very lightly and feel the PSIS move underneath the skin. You're not going to be tracking it necessarily with your thumb, although eventually you'll be fine with that. And then remember all those rules. The patient needs to be like this, holding onto the wall. One contact, the PSIS contact needs to be on the skin. If there's a shirt that's long, underneath the shirt. If the patient has a dress on, as long as it's a long flowy dress, it'll probably be okay. Like summer dress will probably